Let me invite Mr. Sanjeev Sharma, who's the CEO of Utsav Foundation and also the founder of Lung Connect. Dr. Kunal Oswal, who's from Karkinos Healthcare. He is the lead for screening and early detection. Dr. Rushabh Kothari, he's a medical oncologist and director of Oncovin Cancer Center in Ahmedabad. Dr. Chitra Gupta, she's lead patient advocacy at Pfizer. Mr. James Rajakumar, he is associate vice president at Natco Pharma. I welcome you all on the panel and thank you so much for being here and contributing to the cause. Let me start with Dr. Rushabh, because see, what we are going to address over here is like public-private partnership for the development of advocates or advocacies in the cancer care to enhance access, because access is something that cannot be like one of the panelists earlier said that advocacy is something not that cannot be done by one person, or even the government itself is not able to completely drive a big elephant like cancer. So we all have to come together, be it public or be it private players, and that's how the economy or everything has evolved over the period of time. Let me ask Dr. Rushabh that because I'm starting from Dr. Rushabh because he's on the ground, he's facing the patients every day, and he's seeing the real challenges. People ask questions, and things are very different when it comes to the ground level. Dr. Rushabh, what do you think? Uh, how is the implementation when we come to the public-private partnership model? Like you are probably one of the centers who provide Ayushman Bharat or PMJ services to your patients. एंड कहते हैं ना कि खाना कितना भी अच्छा बना लो, अगर खाने वाले को मजा नहीं आए तो मजा नहीं आता है. तो हाउ इज द इम्प्लीमेंटेशन ऑन ग्राउंड एंड व्हाट आर द ट्रू फेसेस ओवर देयर?
So, PMJY Yojana obviously helps a lot of patients. I think that at least 40-50% of the patients would be such that if not this Yojana was not available, they would not have come forward and took treatment or get diagnosed. Having said that, there are some real challenges when we, as a community oncologist, treat patient because the framework is quite restrictive. The biggest challenge is that patient will come with a CT scan. We don't have any biopsy report or anything, and there is no way that PMJY will cover the investigations needed to diagnose a cancer when there is a suspicion of cancer. So that is a challenge, especially when you are not in a government institute. So challenges start there. Again, the second important challenge is the supportive treatment. When you are treating cancer, you see a lot of issues where it is not just chemotherapy or surgery or radiation to be done, but a lot of supportive care goes in. You need nutritional supplementation, you need psychological advice or consult, sometimes palliative care advice, and all this is not covered, unfortunately, in Ayushman Yojana. So obviously, as I told, that at least 40-50% of patients would not have been treated or would not have reached hospital if this Yojana was not there. But these are some points which should genuinely be taken care of. One important point is that, see, we once for any molecule, a patent is over. Our is a country where pharma industry is very quick. They will come up with cheaper molecules, cheaper generics, which again can be catered in Ayushman. So for clinicians, they would be able to understand. We had a drug for breast cancer like palbociclib, which was 70 to 75,000, say in January, it is 5,000. Now, after 1 year of these generics available, it is still not covered in Ayushman. And this is a drug where you can, with the help of which you can delay usage of chemotherapy in breast cancer patients, which improves their quality of life and it improves survival also. So why not to add all these medicines once it is available? So it has to be a dynamic thing. But Ayushman Yojana, once the packages are made, I think the revision or update of the packages are not happening as it should be. Again, unfortunately, some rare malignancies are not covered in Ayushman Yojana, like neuroendocrine tumor or something like that. Though they are not common, but if treated, they can be controlled or cured for longer time. So that is something where oncologists, patient advocates, and everyone can chip in and probably say to the authorities that these are the treatments or these are the leg, and it is not like they are very costly. It is similar to other treatments which are available in Ayushman Yojana. So I understand that we can't have all standard of care, all the best possible treatment in Ayushman Yojana, but it is largely for a general population. But if uh, not very costly but cheaper medicines are available and they can be made available under Ayushman Yojana, that would be of great help to the patients. So this is from patient perspective. The second
जी
perspective which we face a lot in our state is the management. The hospitals which run largely or are dependent on Ayushman Yojana, the cash flow is very erratic because cash flow is not appropriate. With time, hospitals getting discouraged whether to work under this Ayushman Yojana or not. That is getting challenging for some hospitals to survive because most of their patients are under Ayushman Yojana. So that is also something which should be looked at from administrative point of view. I'm not the right person to tell that how it can be done, but sometimes 3 months altogether, and you continue to treat patients, you continue to spend on staff, you continue to spend on drugs, and you don't get the money to run the hospital. So that is something challenging for many of the hospitals.
वेरी वैलिड डॉक्टर साहब बिकॉज खाली पेट्रोल खाली टैंक तो गाड़ी चलेगी नहीं पेट्रोल तो चाहिए एंड देन इट हैज टू बी continuously pumped in and point well taken do you have any vague idea like what do you because this is one platform we would be making white paper out of it that will be going to the NHA Niti Aayog and all the policy makers and other stakeholders as well. Do you have any recommendation vague recommendation even that what how patient advocacy groups can pitch in between and can bridge the gap?
So see, there are some things which can be taken. I think that it is not their intent that they don't want to add something or they don't want to approve something. It is that message should reach them. How would someone know or how would someone change if they don't know generics are available? So I'm not sure, but that is something which we can convey. We can convey the problems which we are facing. So probably all the oncologists who are working in such schemes, at least you form a group of them and they come up with their problems while they are treating patients. Patient themselves can tell the problem that in spite of this yojana, they have to spend XYZ amount on, say, for example, nutrition, on this, on that. And if that can be taken care of, that is something which we as a community, both oncologists and patients, and that patient advocacy can help to imbibe. So at least we can send our message there. And
जी
I hope that because it is not very heavy on cost for them, they would be able to comply to most of the requests.
mm-hmm. Thank you, Dr. Saab. That was a very nice perspective, and I'll come back to you because there is something that we really want to develop, and we really want to help patients or other cancer patients at mass level in our country. And let me move to Mr. Sanjeev, who's founder of Lung Connect, and he also runs Utsav Foundation. संजीव जी जैसे डॉक्टर साहब ने बोला कि एडवोकेसी ग्रुप जो है वो बड़ी इंपॉर्टेंट रोल प्ले करता है और आप बहुत सारा काम कर रहे हैं लंग कैंसर में हेड एंड नेक कैंसर में एंड इन ब्लैडर कैंसर. सो ये बताइए कि कितना आसान या कितना मुश्किल है एक पेशेंट एडवोकेसी रन करना बिकॉज देखिए डॉक्टर साहब ने तो अपने चैलेंजेस बता दी कि भैया पेट्रोल नहीं होगा तो गाड़ी नहीं चलेगी. आपका क्या मानना है?
सो विवेक जी, मेरा आवाज आ रहा है?
बिल्कुल लाउड एंड क्लियर.
थैंक यू, थैंक यू. सो थैंक यू विवेक जी. सब जैसे जिस तरह से डॉक्टर साहब बता रहे हैं कि चैलेंजेस है उनके लिए, उसी तरह से एक एडवोकेसी ग्रुप को भी चलाना बहुत चैलेंजेस है. सो इसमें खास के अगर हम बाहर के देश में बात करें और अपने देश में बात करें, जैसे कि कुछ दिन पहले मुझे भी पता चला कि एडवोकेसी क्या होती है, जबकि हम लोग कर रहे थे बहुत पहले से. अलग अलग तरह की जितने भी काम है सब एडवोकेसी के ही अंदर आते हैं, लेकिन अभी जाके पता चला है उसका असली महत्व क्या है. ठीक है. दूसरी बात है कि एज ए सच कोई फिक्स इनकम नहीं होता है जो भी एडवोकेसी ग्रुप चला रहे हैं. हाँ, तो एक कोई सैलरीड पर्सन नहीं है कि इनको कोई कंपनी है या कोई जैसे कि
फाइनेंशियल मोटिवेशन नहीं है उनको
फाइनेंशियल
कोई।
मोटिवेशन नहीं है कि कोई उनको फंडिंग दे रहा है या कर रहा है, और वो सब अपना काम धाम छोड़ के और पूरा एडवोकेसी में लगे रहे।
हम्म।
तो एक ये सबसे बड़ा चैलेंजेस है। दूसरी बात जो हम देखते हैं, जो कि पेशेंट की बात होती है, बहुत अच्छा, बहुत सारे पेशेंट हैं जो कि अभी अपने बात कर रहे हैं, बात को उठा रहे हैं एडवोकेसी में। लेकिन आप सोचिए कि जब भी हम कोई भी कॉन्फ्रेंस में बैठते हैं तो वहां पे बात होती है कि पर ईयर 14 लाख पेशेंट डायग्नोस्ड होते हैं कैंसर से। उसमें से कितने परसेंट सर्वाइवर है? 50% मानते हैं, 40% मानते हैं, 30% मानते हैं, किसी में 70% भी बोलते हैं। इतने पेशेंट जब इससे अच्छे हो रहे हैं, और इसमें से जबकि सबको पता है कि फायदा आगे चल के सबको होने वाले हैं, फिर भी बहुत कम लोग आगे आते हैं इस चीज को करने के लिए। तो ये भी एक बहुत चैलेंजेस है जो कि हमें पेशेंट और केयर गिवर को आगे बढ़ के आना चाहिए। और हमारे यहाँ एक कहावत है, जब चुएंगे तो छाड़ेंगे, और जब वो काम हो जाती है फिर उस चीज को भूल जाते हैं। तो दोनों तरह से है कि एक स्टेबिलिटी नहीं है कि कोई ऑर्गेनाइजेशन की फंडिंग की कोई लाइफ नहीं है इसमें, कोई कैरियर नहीं है इसमें। और दूसरी बात, पेशेंट और केयर गिवर में बाकी देश की तरह अवेयरनेस नहीं है। जैसे अभी आपको पता है विवेक जी, पिछले साल हम गए थे मैड्रिड वर्ल्ड ब्लैडर कैंसर कंसोर्टियम को रिप्रेजेंट करने के लिए।
जी।
वहां पे एडवोकेसी के लिए हैं बहुत सारे लोग, उनके स्पेशल सीईओ हैं, स्पेशल लोग काम कर रहे हैं, सब चीज उनका काम ही है सिर्फ एडवोकेसी करना। हमारे यहाँ अनफॉर्चुनेट अभी ये चीजें नहीं है, बट धीरे धीरे होगा। इंडस्ट्री आगे आएंगे, लोग आगे आएंगे, वो होगा। तो ये सबसे बड़ा दो चैलेंजेस है विवेक जी।
तो हमारे यहाँ जो काम फुल पार्ट टाइम है उनके यहाँ फुल टाइम है, और जो उनके यहाँ फुल टाइम हमारे यहाँ पार्ट टाइम है।
जी जी जी।
अच्छा संजीव जी, जैसे हम बात कर रहे हैं एडवोकेसी के जो चैलेंजेस हैं, ठीक है। नाउ मान लीजिए कि इतने सारे लोग देख रहे हैं, करीब 20,000 लोग जुड़े हैं हमारे पास। कोई अगर इसमें से यक्ष बन के सामने खड़ा हो जाए कि बोलो मांगो बच्चा क्या चाहिए, तो क्या दो तीन चीजें होंगी जो आपको लगता है कि जो अगर हमें मिल जाए तो हम बेहतर तरीके से जो है रन कर सकते हैं?
एक तो सबसे पहला टाइम चाहिए। जैसे कि सभी लोग यहाँ पे, मैं जितने देर से सुन रहा हूँ कि सभी लोग बोल रहे हैं कि डॉक्टर अपने तरफ से, जैसे अभी समीर सर बोल के गए कि मैंने अप्रोच किया, एक को मिला एक को नहीं मिला, 50% ये हुआ, चीजों को हुआ। तो सबसे पहले तो टाइम चाहिए, जो पेशेंट और केयर गिवर हैं देने के लिए इसमें। दूसरी चीज फिर मैं वही बोलूंगा कि ऑर्गेनाइजेशन रन करने के लिए आपको पैसे की जरूरत है। तो जिस तरह से सीएसआर या कोई भी ट्रस्ट आकर को, कोई पेशेंट बीमार है उनके लिए, मैं ही बोलता हूं कि मुझे आज किसी को बोन मेरो ट्रांसप्लांट है, अगर उसको गाइड करना है, उसके लिए 12 लाख रुपया जमा करना है या 20 लाख रुपया जमा करना है, हम बता देंगे, गाइड कर देंगे, हो जाएगी। लेकिन अगर किसी एक नेविगेटर के लिए ढूंढना है कि वो महीने में 300 पेशेंट को हेल्प करते हैं, पर पेशेंट 100 रुपया का खर्च आता है, तो देने के लिए कोई तैयार नहीं है। चाहे जो भी रीजन हो, हम रीजन में नहीं जाते हैं। तो ये दो चीज, एक तो सबसे पहले जिस तरह से लोग बाकी चीजों के लिए व्यवस्था करते हैं, उस तरह से लोग इसमें भी हेल्प करना चाहिए, स्पेशली एडवोकेसी के लिए। और दूसरा है, पेशेंट और केयर गिवर को टाइम देना चाहिए। और तीसरा, बिना डॉक्टर्स के सपोर्ट के हम लोग कुछ नहीं कर सकते हैं, क्योंकि उनके भी हेल्प, मेडिकल के भी लोगों की हेल्प उतना ही जरूरी है हमें गाइड करने के लिए। बोलो जी विवेक जी।
जी बिल्कुल, आई कम्प्लीटली अग्री, बिकॉज इवेंचुअली पेशेंट्स आते हैं डॉक्टर के पास और ट्रीट भी उनको डॉक्टर ही करने वाले हैं। वी काइंड ऑफ लाइक एडवोकेसी ग्रुप्स और forums like you and me, probably we need to bridge the gap and stay as a bridge amongst both the stakeholders. Now let me come to डॉक्टर कुणाल। डॉक्टर कुणाल, आपने सुना कि कितने सारे चैलेंजेस हैं, डॉक्टर लेवल पे भी चैलेंजेस हैं और एडवोकेसी लेवल पे भी चैलेंजेस है। और ये चैलेंजेस तो हम वो बात कर रहे हैं ट्रीटमेंट रिलेटेड चैलेंजेस, और इसमें तो आप बहुत मुश्किल सा काम कर रहे हैं, मुझे ऐसा लगता है कि बिकॉज यू आर वर्किंग ऑन अर्ली डिटेक्शन एंड स्क्रीनिंग, how difficult it is, like what all roadblocks you get when it comes to early detection and screening, because as Sanjeev ji mentioned right away, like, people are more willing to contribute or, be whatever way, be it financially, be it time wise or any other way for the treatment rather than early detection or something, because we take motor insurance 100%, but for our health we go to temple or whichever place of worship we have. So how difficult is your work? What all roadblocks you are facing, and do you think that patient advocacy groups can play any role in that?
Thank you, Vivekji, for having us, Karkinos, and thank you, Cancer Conclave and Dr. Kumar Professor. All of you all are instrumental in shaping this, especially the World Cancer Day, where Close the Cancer Gap is. And Vivek, you are right. You have hit the nail in the coffin. Everyone talks about early detection, but when we go and ask people to come forward for screening, there will be n number of reasons why they don't want to come. And per se, if I see historically, the disease is, how it has portrayed through the media, through the whatever media we say, whether it's a social media, print media, online media, it's always like C is equal to death. So पहला वो सी वर्ड सुन के लोगों को रहता है कि ओ इट्स डेथ फियर अनसर्टेनिटी रहता है एंड इवन इफ व्हेन वी वांट टू we know that there is an evidence that early detection save lives. Cancer can be picked up early. Few cancers we have a proper screening test which are available. Still, they will not come as compared to other diseases when we talk about, say, diabetes or hypertension, where everyone will come forward. Okay, I need to check my blood pressure or I need to go for my sugar check. But when it comes to cancer, it is a lot of stigma still, fear. I think if we look from the other diseases, when in 1990s HIV was at the peak, the social media and the was very revolutionized, and they really came forward with a very mass media campaigns where you destigmatize a particular disease. So same way we need to learn from the other disciplines and other practices key how this C word can be tackled. We all know the government reports that hardly 1 to 2%, except Tamil Nadu, where the percentage is high, hardly 2% people come forward for screening. And when we also rolled out our campaigns across the country, we started from in Karkinos, from Kerala and Manipur. We adopted the local cultural influences. In previous speaker also, when palliative care I was listening, is the volunteer support group. So Kudum Shri, the self-help groups. These are the champions who are there, who are existing networks which are available in our country. And if we can imbibe our our programs to them, it creates a last mile. Coming to patient advisory group or patient advocacy group, I think they are the core. If you want to get certain things done, the PAG, patient advocacy group, would be at the forefront. And we have demonstrated the results in previous role. We had created the, say, for tobacco, Voice of Tobacco Victims, which was the brainchild of Dr. Pankaj Chaturvedi from Tata Memorial Hospital. We created this forum for advocacy itself. And we were able to put government policies, whether it's, ban of smoking in public places, ban in gutka, educational sales. It has a wider impact at the policy level as well as at the state level, where the policymakers wants, okay, what you want, tell me what the policy is. So similarly, whatever materials we are designing, the advocacy group can give a lot of insights. When we design our a screening program, is this material communicating rather than being more confrontational or scary? Can this information be communicated in a better way? Can this be simplified so that the local people can participate? How can we engage them? And time to time, they can give a lot of vital insights which can change the program.
डॉक्टर साहब, अच्छा पर्सपेक्टिव दिया आपने एंड आई एम रियली ग्रेटफुल टू यू। मेरा एक फॉलोअप क्वेश्चन है, यूं कह लीजिए कि जैसे आपने से एचआईवी की बात करी और स्टिग्मा की बात करी। हमारे देश में जब एचआईवी की बातें करते हैं, आज एचआईवी एक काइंड ऑफ हिस्ट्री हो गया, मतलब इट्स क्वाइट
Right.
वेल एक्सेप्टेड थिंग। पोलियो तो अभी खत्म भी हो गया है, बट देयर प्रोबेबली लोगों को पता होता था कि भाई ये इसकी वजह से होता है, ये 1 2 3 4 कारण है उसकी वजह से होता है। कैंसर में ठीक है, लाइक देयर इज 1% ऑफ, जैसे आपने पंकज सर का नाम लिया कि मतलब वो इतनी बड़ी इनिशिएटिव चला रहे हो प्रिवेंटिव ऑन्कोलॉजी की, बट स्टिल इट इज नॉट 100%। सो उसमें स्टिग्मा एंड जब लाइक इफ वी कंपेयर लाइक जो पास में, बिकॉज दिस इज हाउ वी लर्न कि पहले क्या हुआ था, उससे कुछ सीखते हैं और आगे बढ़ते हैं। तो उसमें कैंसर को लेकर जो स्टिग्मा है उसको कैसे कम किया जा सकता है? दिस इज अ क्वेश्चन टू एनी ऑफ द पैनलिस्ट कैन shed light on, because we are going to work on these things, and we need a lot of intervention, we need a lot of guidance and support. So when it comes to stigma, because देखिए कैसे हम कितना भी काम कर लें, जब तक डिटेक्शन अर्ली नहीं होगा, लोग द डेथ, कैंसर विल रिमेन डेथ सेंटेंस अनलेस वी डिटेक्ट देम अर्ली एंड वी स्क्रीन। बट दैट इज अ वेरी बिग डील, लाइक आपने जैसे बताया कि जब स्क्रीनिंग की बात आती है, छोटे छोटे रीजन देके लोग आते नहीं है कैंप के लिए, जो कि फ्री स्क्रीनिंग होती है, उनके डोर स्टेप पे आप जाके करवाना चाहते हो तो भी नहीं आते हैं। सो हाउ डू वी लाइक, क्या वो एक दो चीजें हो सकती हैं जो आपको लगता है कि फॉर ओपन फॉर एनी पैनलिस्ट?
You want me to go first? I'll go
प्लीज
first. Yeah.
प्लीज प्लीज।
Like I think these forums, like what Vivek, you and Kumar sir is doing, is really instrumental. And now, as you said, 20+ K people are seeing that. So the more we talk about, the more we share that it's normal to, and we all know that in every family there will be one cancer patients, either family or relatives, yeah, in their neighborhood. It's not that कि पहले था कि कैंसर ये बाजू वाले का डिजीज है. It's not that कि मुझे नहीं होगा बाजू वाले को होगा. Now it is that every person or has that experience. So the more we talk about it, now the recent budget also clearly says that vaccination for girls. So uh, at policy level there is a thrust, at local level, state and the central level, the hospitals are coming up, and as a movement, participatory movement, the more we engage this, especially with the young generation, they are amenable to information. The way सोशल मीडिया हो गया है आजकल, टिकटॉक और रील्स ज्यादा देखते हैं रादर देन एक एंटी टबैको कैंपेन मुकेश हरने का. सो वी हैव टू लर्न कि क्या चीजें होती है एंड क्विकली एडप्ट एंड रिकोर्स आवर एक्शंस कि ओके ये चीजें चल रही, हाउ कैन आई पेनिट्रेट माय मैसेज, हाउ कैन आई. इट्स नॉट ओनली अर्ली डिटेक्शन, इट्स डिटेक्शन है, डायग्नोसिस है, ट्रीटमेंट, फॉलोअप केयर, एंटायर जर्नी में each way पे how can I do my best communication which is non-confrontational, non-threatening. So one is that. And second, through a support group and through this initiatives where access to information can be given to the patient, whether not only the patient but caregiver also, ताकि उसको पता रहे कि ओके अभी मेरे को नेक्स्ट स्टेप ये करना है, आई हैव टू गो हियर और आई हैव टू डू 1 2 3. That will help us to bring down the cost significantly, because two things are there. One is the fear of death and second is the cost implications. Previously the insurance segment covered extensively, but through this constant dialogue and your white paper with constant advocacy, I think we'll have some roadmap to go ahead. I'll pause here.
Thank you, Dr. Saab. Anyone would like to add, or we should move to the next question? Okay, so yeah, James, you wanted to say something?
Yeah, Vivek, I think, hope I'm audible.
Yeah, absolutely.
Yeah. I think we both have discussed this at one point of time. In today's penetration of YouTube videos and digital media, I think we can use the advocacies, patient advocacies, and can use the patient survivors as their ambassadors of the good news. Like Dr. Kunal is talked about fear. There's a lot of fear even among the educated society, even in metro cities. I have a friend of mine, PhD in organic chemistry. His own wife, well-educated lady, ignored all the early signs and finally had a very dismal prognosis. Dr. Kunal was mentioning about the early signs, early detection. Many of the people ignore because of the fear. I mean, they are compelled to ignore because of the fear. So we need to get out of this fear psychology only through positive messages. And Dr. Nal also pointed out another psychological aspect, that this cancer as a word is always related to death. I think we need to change that. We need to give a positive outlook that there is a lot of hope with the kind of immunotherapies and the CAR T cells and the kind of therapies which are coming out. The survival graph is always looking brighter and brighter day by day. This message, instead of you and me, or instead of a medical professional talking about it, if patients could talk as an ambassador of this good message, I think the reach will be better. And we have been using digital media to a great extent in this front. but there could be some limitations when it comes to rural, wherein advocacies can have their own regional or their local groups to take it forward.
Thank you so much. Thank you so much. It's very valid thing, and I think probably if Sanjeev is also here, we quite a lot work together, and probably taking the cue from your statement, we think that we are moving in the right direction. And let me come back to Chitra. एक सवाल है, जब कैंसर की बात करते हैं तो बड़ा ही कॉम्प्लेक्स चीज है ये। मतलब जैसे मैं वो यक्ष की बात कर रहा था, तो अगर यक्ष आ जाए तो आज यक्ष भी परेशान हो जाएगा, यार इनको ये भी चाहिए, ये भी चाहिए, ये भी चाहिए, ये भी चाहिए, इतनी सारी चीजें हैं मांगने के लिए। सो जहाँ एक तरफ एकोमोडेशन से लेकर खाने तक के चैलेंजेस होते हैं, लोगों को ट्रैवल करने के चैलेंजेस होते हैं, दवाइयों के चैलेंजेस होते हैं, बहुत सारी चीज़ों के चैलेंजेस होते हैं। तो एक एक कंपनी जैसे फाइजर को आप रिप्रेजेंट करती हैं, तो मतलब कुछ ऐसे इनिशिएटिव्स हैं जो आपको लगता है कि हमारे प्लेटफॉर्म के माध्यम से लोगों को जानना चाहिए कि इस तरह के कॉन्ट्रीब्यूशंस हैं, एंड आप उम्मीद बनाए रखिए।
Thank you so much, Vivek, and thank you so much for inviting for this conference. I'm hearing it for last few hours since its beginning, and it's really a fantastic discussion, which is much needed to continue and more regularize. So answering to your question, and first of all, the topic of this panel is PPP, public-private partnership, which we generally use as it's a cliche. And I think one P is missing here, which we all are talking about, the public, private and patient partnerships, which we are discussing. And, and what you're asking is like, there are what we do. No, but that partnership is very, very important, because that is whatever we do, or as a government, they do, everything is around patient. And your voice is very important as a patient. And that has to be represented, and that's getting even more stronger with this information and right kind of capacities and empowerment of the patient groups. So when you talk about the hope and the kind of things which we do when it comes to the access programs, maybe I can just talk about that little bit. So as a pharma company, and the cost and affordability are mostly talked about. Access and affordability and coverage, which so far has been discussed in every panel, and you are going to discuss this again in the next panel also. I think to do our bit, we have, and not only we, means entire industry has innovative access programs around their therapies, and where we support patients, those who are inadequately or not covered by any scheme or a private or public scheme. So and paying mostly out of the pocket. So that in those cases we have patient assistance programs where part of the cost of the treatment is borne by the patient and part of the cost is borne by the company, and that helps the affordability piece. And as we are growing, having more, coverage by, and I hope this discussion is going to really lead to a lot of advancements and hopes in future. And Dr. Prakash, as he has just upfront offered his support in designing new packages, I think it's going to be very bright. But when it comes to patient assistance access programs, we are trying to support as many as patients through this model where we lift part of the cost and patient lift part of the cost, and the patient groups certainly have a big role in partnerships when it comes to the patient access programs, because your voice is very, very important in this case. And some information dissymmetry is and your voice is missing, because in this case, we are not the one who are dealing with the patients, or we are in touch with the patients who are getting benefited. Because of our regulations, we are dependent on the third parties who deal with these things. And so in this case, like we don't know, except numbers, we don't know what is the impact. So I think the patient groups will be very important to help us in getting the impact and talking about this broadly, so that these programs have a long life. These programs have ability to support many more people, and they are continued in the long term. So this is something, and apart from that, there is a lot around in these programs, the patient access programs, because as I said, it's the third parties who implement these. So there's a whole cycle around these programs where the enrollment happens, validation happens, then the dispensation, the distribution of medicines happens, and there are various chances of where patient is finding any challenges, and whether the time or the process, cumbersome process. So again, as a patient groups, the representation of the voice, where you can talk to us, you can let us know what are the challenges you are facing, and we can always help improving the efficiency of this entire process in a patient friendly way. So these are a few points, if that answers to your question. And means I can say that we have also discussed a lot in previous panels about various funding mechanisms. So there are possibility of even reducing the burden which is currently there in patient access programs or otherwise, who are not even able to get this support of access programs also. So there are various ways where you can create the fund, where the means if I think upfront like their superannuation fund was discussed, CSR fund is anyways supporting. So there are various ways where such funds can be created, where the interest-free loans can be given to the patients. So means I think these innovative financing models are very, very important to be discussed, and you will find a lot of practices around you which can be then taken forward from other disease areas, or means within the cancer itself, from country, outside the country, that can be explored.
जी, जब हालांकि हम यहाँ पे बड़े एक्सपर्ट्स के साथ में बात कर रहे हैं, लेकिन इस प्रोग्राम को मैंने जस्ट अभी थोड़ी देर पहले स्क्रीन फ्लिप किया था, तो देखा करीब करीब 25,000 लोग हमें वॉच कर रहे हैं लाइव ऑन यूट्यूब स्ट्रीम। तो बड़ी रिस्पॉन्सिबिलिटी के साथ हम यहाँ पे ये बातें कर रहे हैं, और आई एम सो ग्रेटफुल टू ऑल ऑफ यू फॉर कॉन्ट्रीब्यूटिंग एंड मेकिंग सो मच सेंस दैट सो मेनी पीपल आर अलाइंड। बिकॉज मुझे नहीं लगता कि कैंसर कॉन्क्लेव जैसे इवेंट को कोई जो है नॉर्मल आदमी या कोई एंटरटेनमेंट के तौर पे तो नहीं देख रहा होगा। आई एम श्योर दे वुड बी सीरियस पीपल। जेम्स जी, लेट मी कम बैक टू यू विद, जैसे हम बात करते हैं, जब एक्सेस की बात करते हैं, तो एक्सेस में ना, वैसे तो हम देखिए, हम बात कितनी भी कर रहे हैं आज केयर की, जैसे अभी डॉक्टर साहब ने बताया कि कितना भी कुछ हो गया है, लेकिन कैंसर जो है वो डेथ सेंटेंस तो है। मतलब हम लोगों के लिए, डॉक्टर कुमार ने भी शेयर किया था कि भाई जब एक एक वो पर्सपेक्टिव होता है, जब हम टेबल के उस पार देखते हैं, उस पार देखते हैं, तो चीज़ें अलग नजर आती हैं। जब एक्सेस की बात करते हैं तो दवाई का जो है बड़ा महत्वपूर्ण स्थान है। इट्स वेरी इंपॉर्टेंट प्लेस और वेरी इंपॉर्टेंट पार्ट टू प्ले। So, what all are the things, like, if we are trying to reduce the cost, there could be multiple ways. Like, one thing, as Dr. Chitra said, that part payment kind of thing. There are people who are donating nutrition things and other things. So, to reduce the cost, there could be a lot of things. But since your expertise and domain is into manufacturing or the pharmaceutical, or especially cancer, and NATCO is a very premier name. Like, you had been serving the industry for quite many years, and very successfully. So what do you think that while when it comes to access to the drug, are we done enough? Like, the cost reduction and other things, are we done enough, or there is still scope of doing something, or how do you take this?
So when you talk about access, a lot has happened between 2003 and now, probably 21 years. Why I'm taking 2003 as a point in the history, because that's when the first targeted therapy was introduced, which brought in a sea change, and subsequently a lot of oral as well as injectable targeted therapies came in, and that's what increased the survival graph in most of the cancers. So that's why I've taken 2003. Between 2003 and now, there's a lot of things have been positively done in the aspect of pricing. So I'll take example, one of the product which was introduced in 2003, which has completed 20 years now, that's in CML, costed 1,10,000 per month of therapy. I'm sorry, for a month therapy. And this drug needs to be taken lifelong. And the generics brought it down to 10,000 Indian rupees. And today it is available for 900 Indian rupees, even from a reputed company. So this is possible, and this is what has happened with all the synthetic drugs, the synthetic chemistry-based drugs. This is what has happened. To that tune, the price has been reduced. But at the same breath, I would like to say that you cannot stretch it beyond this. It is literally, the industry is bleeding. That's the kind of word I would be comfortable in using. It is not from a sense of revenue or profit, but from a sense of viability. You cannot, for that example, the drug which I said, you cannot go down below the costing of 900 rupees to the patient. It's to the brim, it's to the seam, and anything below that, it's going to put many things in question. So coming to the next set of drugs, the conventional monoclonals, yes, the biosimilars have brought down the price. Similar to what I said, it's not 900. You'll have to take the technology, the wastage, the build-up, everything into consideration. If you do that, most of the biosimilar monoclonals, the conventional ones, have been brought down in a range of anywhere between, let's say, 9,000 to 15,000. From a initial price of, let's say, 1.5 lakhs or 1 lakh. So again, the price has been brought down to the point of affordability. And if you talk about immunotherapies, and if you talk about antibody drug conjugates, currently they are available at about 75,000 rupees per month. With all the best access programs, still they would cost 75,000 rupees and above. Few exceptions could be there. Most of them are in that range, what I said. So keeping into consideration the kind of survival graph, which I mean, the impact on the survival graph they have brought about. Let's say the patient is going to take it in an adjuvant setting. The period he is going to take is quite long, or maybe in a maintenance setting, it's going to be quite long. So definitely there's a need for biosimilars in that segment. But again, it may not come down below 20,000. But the question to be answered is, there are patients who are getting treated in corporate hospitals. There are patients who are getting treated in teaching institutions like AIMS, TMH, or Kidwai, or Adayar kind of centers. They are totally different from the corporate clientele. And there are also patients who are getting treated in state-run centers, which is typically run by the procurement of the state medical corporations and the government hospitals. And there's a small set of patients. If you want the percentage, roughly around 35 to 37% of patients are getting treated in the state-run centers, and around 28% of patients are getting treated in the premier teaching institutes, and around 30% of patients are getting treated in corporate, and 5 to 7% of patients are getting treated in the panel. That's the ESI, CGHS, railways, DGFMS, and all those. So if you look at the segment of panel patients, everything is borne by their employers. If you look at both the state-run government hospitals as well as the premier teaching institutions, the availability of Ayushman Bharat and the state-run schemes have eased the access to a great extent, but you cannot expect government to spend for everything when drugs are so expensive, especially the immunotherapies. The pharma companies, both the multinationals as well as the Indian companies, have done justice to the pricing to a very great extent. But if you really explore the possibilities, yes, it does exist in immunotherapies and the newer therapies that are yet to come, but not in the synthetic chemistry drug. Now, talking about corporate hospitals, yes, there is an inbuilt affordability in that class of patients. But coming back to immunotherapies, even a biosimilar wouldn't make it possible less than 20,000 per month. And it is not viable. It is not going to be viable for any company to operate below 20,000 price point. If that is so, then how do you take this therapy to, let's say, Ayushman Bharat? How do you take it to state-run hospitals? How do you take it to the patients who are getting treated in premier teaching institutions? That's the place where health insurance, as a community, we need to, as an Indian community, we need to embrace health insurance at this point of time. If you look at CAR T cell therapy, even in a relapsed refractory setting of lymphomas or ALL, there are patients, including the first patient, Emily Whitehead. She's living for, let's say, more than a decade plus she's alive, and the response, the drug has been a living drug in the body. Do you think it can be brought down below 1,000 rupees? It's simply, I mean, even in dreams it happens. So the point I'm trying to make is there is a limit to bring down the price where the viability exists. So the affordability is not going to define access to treatment. Access to treatment is multifactorial. I mean, affordability is one part of that composite. And if you give anything free, unfortunately, the importance is lost. Sometimes I'm not cynical about it, but then
I agree.
Sometimes sometimes it loses its significance to a great extent. That's why I strongly believe that all of us should work together in bringing the right kind of awareness among people. Before going to awareness, when you talk about access, affordability is just one factor of that multifactorial thing. So the major thing, before you talk about treatment, you need to diagnose. Do we have the infrastructure, especially in a rural area? This is where recently, 1 month back, the central government has announced a plan that they will set up basic diagnostic capability in all the primary health centers and then refer the patient to the district or the regional cancer center. This is going to improve your access to the treatment. And the second thing is the point which you all talked about a little earlier, awareness. Awareness is complicated by a lot of local practices, social practices, cultural practices, and most importantly, the myths and the misconceptions that are working against even a simple procedure like a biopsy is questioned. People believe that once you take a biopsy, there's a lot of tumor spillage and the tumor will spread to different parts of the body. I mean, in 2023, people are not willing to do simple investigation like biopsy. So where are we in a scale of awareness? Probably in 1 or 2. So we need to increase the awareness by busting all the myths and the misconceptions, not only in rural and semi-rural, even in urban areas, even among the educated public, lot of misconceptions. So we need to bring in a lot of awareness. And of course, the infra which we talk about at the primary health center, there should be some modality to diagnose at the early part of the disease. And Dr. Kunal has emphasized on the screening part. Today, people are screening for breast cancer and head and neck cancer. But how about other cancers? Cervical cancer. Somebody mentioned about the vaccination program, which was announced. I think we are on the right track, but then the pace at which we are moving versus the pace at which cancer is advancing. Somebody talked about 14 lakh cancer cases as incidents. That's based on the community-based and hospital-based cancer registries. It's an extrapolated data. It's not a real-time data. And many of the oncologists feel that we will be having an incidence of 20 lakhs and above per year. So that puts the prevalence probably 40 lakhs and above. So the WHO has said that 1 out of every 10 Indian is at the risk of cancer. And today, 4 out of 10 Indians have a fatty liver. It need not progress to cirrhosis. The risk of transforming into a HCC is quite there. So when you look at different compartments, different tissue-based cancers, everything is progressing at a fast pace, whereas our awareness, our infrastructure is not up to the pace. But having said that, I would also like to congratulate the efforts taken by the central government. States like Northeast, I mean, many of the sister states in 7 sister states in Northeast were lagging behind many of the other states. But today, if you go to Assam, you have Assam Cancer Center-based, government-supported cancer treatment centers almost in every city. I don't know how many of them have heard about Barbeta or Jorhat. Dibrugarh, definitely everybody would have. Tezpur, people would not have heard about. Today, you have cancer centers there. It's because of the single-minded focus to get out of this cancer, because this is a state, I mean, both West Bengal as well as Northeast. In the early 2000s, they used to travel thousands of kilometers to either Mumbai TMH or to the southern cities, southern states. But today, they need not travel even to Guwahati. They can get treated in their respective states. So definitely government has also made a lot of progress. Probably the pace at which we build the infra to diagnose and treat would make a considerable difference to access to treatment. It is not necessarily affordability. Affordability is stretched up to the seam, because I've been part of this industry. I mean, this oncology for the last 20 years and industry 30 plus years. And I know where viability becomes a non-existent thing. And in fact, not just multinationals, even Indian companies, generic companies have withdrawn many products because of non-viability. Cancer is not like a cough syrup or an anti-inflammatory with huge unit volume. When you have a huge unit volume turnover, you can have least margin and you can operate. But in oncology, hardly 25% of patients get treated out of the incident population. When we talk about, let's say, either 14 lakhs or 20 lakhs as incidents, in 2000, hardly 10% was getting treated. Today, for a palpable tumor like breast, maybe 30% is getting treated. For a visible tumor like head and neck cancer, maybe 35% or 40% is getting treated. But those tumors are not visible, not really bothersome. They blow up in the last stage. Let's talk about acute myeloid leukemia or any type of leukemia. It doesn't really bother you till it really shows up in the last stage, or a pancreatic cancer.
Correct.
The percentage of patients getting treated is very less. Some of them are as dismal as 15%. Some of them are 20. That's how even today in our country, out of the incidents, only 20-25% average consolidated is getting treated. This is where we need to improve. This is where we need to build up the infra, I mean, spread more awareness, bring in more hope around the cancer treatment. I mean, talking about the pricing, which you expressed as a concern, I think the industry together, both the multinationals as well as the Indian companies, have done their best in bringing the product at the best possible price. Maybe immunotherapies in the days to come will definitely see such kind of a price reduction. Over to you.
Thank you so much, Mr. James. And I see my fellow, subsequent moderator Ratna ji being here, and I'm having some pressure because we are running late because the discussions are so interesting and so intense that you just cannot pull out in between. We have to do a lot of work, and we'll keep meeting, we'll keep discussing. But before I wrap up my session, I have two small questions. Maybe we'll try to answer in 2-3 minutes. One, I'll come to Chitra. Chitra, because you are associated with, you had been part of various public policy organization, and you have done a lot of work in that direction. What do you think that pharma companies and patient advocacies के बीच में किस तरह का collaboration हो सकता है? What all are the things, like maybe a couple of examples if you have.
See, there are already so many examples, Vivek. So one example I gave you, like to adhere the patients to the therapy, to continue the treatment. There are a lot of things, even means as a practice, we have, we are very patient-centric company, and we always try to get the patient insight, because that is something is very, very important what you are preparing for somebody, even if it's a small literature or awareness material. You have to hear what patient is, whether they are able to understand or not, right? So it is a very simple to complex examples. And now when you're talking about Ayushman Bharat, insurance, I think there are a lot of things, even the innovative funding, global practices, there are a lot of ways the patient the advocacy groups can be strengthened and empowered by various stakeholders, not only pharma companies, but various other stakeholders like Maulik was there from a financial, this economic background. There are possibilities, various models of collaboration. We collaborate in various ways. For example, Sanjeev ji knows when the COVID time, there was no channel, and most of the people at that time were facing a lot of same problems, and somebody supported. So it's in lung cancer case, probably we and few companies supported. So there was a need to establish a quick channel where patients who were struggling to get the prescription, right? So they needed some channel to get their prescriptions, consultations. So then the entire e-platforms and everything came up. So there are various ways, even the empowerment, capacity building, small things in very minor. We may think it's a small matter to how to do a Zoom meeting, but not for everybody. Right. So there are so many things where we collaborate. Recently, we have launched a global platform, which is Patient Advocacy Leadership Collective. And that is all basis on the input and surveys of the patient groups in more than 25 countries and more than 170 patient advocates, where we have collected what they need when it comes to capacity building. It's not me who deciding what you need. Actually, you should say what do you need, and then a collective representation. Basis on that, course has been designed by various universities, more than 50-60 courses, and those courses are also endorsed and designed by the patient advocates with the help of experts, and now patients groups are going to use those things. We have our help desk in more than 14 hospitals, COEs in country, the Asta help desk. Again, that's a patient navigator tool where we have touched, I have some data, more than 104,000, means it's the October data, where we have touched more than 1 lakh caregivers, more than 3 lakh patients, and helping them into accessing the, what are the different financial options, what are the places you can go, how to navigate the entire hospital, then, counseling. So there are a lot of things where partnering and possibilities to partner across the spectrum, whether it is awareness, whether it is advocacy, early diagnostics, and education, empowerment. The possibilities are enormous. It has no limits. Thank you.
Thank you so much, Dr. Chitra. संजीव जी, एक लास्ट सवाल, बिकॉज देखिए पेशेंट एडवोकेसी या सपोर्ट ग्रुप, ये जो चीजें हैं हमने अभी शुरू करी हैं, शुरू इसलिए क्योंकि मतलब ये 20-25-30 साल पुरानी नहीं है, इन लास्ट फ्यू इयर्स इट हैज इवॉल्व्ड, एंड मुझे लगता है कि आप भी एग्री करते हैं कि बहुत काम अभी करे जाने की जरूरत है. देयर इज अ लॉट टू बी डन. सो जो नए लोग आएंगे या जो लोग हमसे जुड़ना चाहते हैं, साथ आना चाहते हैं, उनके लिए क्या संदेश देना चाहेंगे आप?
जैसे आप बोल रहे हैं बहुत करने का, सपोर्ट ग्रुप, फिजिकल सपोर्ट ग्रुप तो हम लोग चालू कर दिए थे 2008-9 से ही होता था, लेकिन ऑनलाइन, जिसे चित्रा जी बोल रहे हैं, ऑनलाइन सपोर्ट ग्रुप हम लोगों ने कोविड में चालू किया. 1 मिनट लूंगा आपका. जैसे जेम्स जी ने भी बोल रहे थे कि रूरल एरिया में कैसे करेंगे, तो सपोर्ट ग्रुप हम चालू कर दिए थे. और जो हमारा यूट्यूब का चैनल का जो आइडिया आया था, हमें रूरल से ही आया था. मैं गांव गया था और घर से मैं जब सो के उठा और मेरे घर में 3 लोग खाना बना रहे थे और तीनों यूट्यूब ऐसे देख रहे. हाँ, तो सोशल मीडिया मुझे पता था, लेकिन मुझे वहां पे लगा कि यूट्यूब
इतना गजब का रीच होगा वो नहीं पता था.
हाँ, वही चीजें हैं. और वो आके फिर प्रभात थे, मैं था, विवेक थे, कुमार सर थे, हम लोग ने बहुत सारे लोग बैठे और डिस्कस किए. एंड 1 साल में हम लोगों ने यूट्यूब लंग कनेक्ट के यूट्यूब चैनल पे लगभग 100 से ऊपर वीडियो डाले हैं लंग कैंसर के बारे में. एजुकेशन वीडियो, और जो भी है हमारे ऑथेंटिक डॉक्टर के द्वारा है. और यही चीजें, यहाँ पे डॉक्टर कुणाल बैठे हैं, मिस्टर बैंकट से मेरा बात हो रहा था कि 2025 लास्ट तक जितने लोग लंग कैंसर में गूगल को सर्च करते हैं, उससे ज्यादा लंग कनेक्ट को सर्च करना चाहिए. इतना हम ऑथेंटिक उसमें चीजें को दें. तो ये रूलर का था. दूसरी बात है विवेक जी, सबसे बड़ी बात है ना कि कोई भी, बहुत सारे ऑर्गेनाइजेशन हैं, पेशेंट हैं, आप देखेंगे, हम तो देख रहे हैं हिंदुस्तान में, मैं 20-25 साल से इसमें हूँ, 2-3 लोग ही देश को प्रेजेंट कर रहे हैं इतने सालों से. हाँ, 3-4 आदमी से ज्यादा नहीं मिलेगा आपको, चाहे वो पेशेंट हो या फिर ऑर्गेनाइजेशन भी हो. बाकी जो छोटे छोटे अपने काम करते हैं और उसमें लगे रहते हैं चीजों को. तो सबसे जरूरी है कि अगर यूनाइट होना है, हमें एक साथ ये सारी चीजों के लिए कुछ चेंजेस लाना है, तो एक होना पड़ेगा सबसे पहले। अकेले हम कुछ नहीं कर सकते हैं, ज्यादा ज्यादा हम ये कर सकते हैं, ये बन के ही हम लोग कुछ कर सकते हैं। तो सबसे बड़ी बात यह है। दूसरी बात, मैं जैसे पहले भी बोला था कि टाइम निकालना पड़ेगा, सब पेशेंट को खास के बात है जो है, और इंडस्ट्री को साथ देना पड़ेगा, चाहे वो CSR हो, ट्रस्ट हो, या फार्मा इंडस्ट्री हो। और जो डॉक्टर का तो साथ होता ही है, वो लोग तो चाहते ही हैं कि जितने अच्छे से हो सके।
जी,
ठीक है, थैंक यू।
Thank you so much, Sanjeev ji. And I think we tried to understand that how we, like industry and other, public patient partnership, rather, rather than only the policy, because सरकार तो अपना काम कर रही है, but सरकार को उसके काम को और अच्छे से implement करने के लिए how we all can come together and we can create or rather co-create a community that empowers everybody till the last mile. Thank you so much.
एक लास्ट चीज विवेक जी में बोल रहा हूँ कि कैंसर एक ऐसा जंग है जिसमें अगर कोई भी सपोर्ट कर रहे हैं थोड़ा सा भी, उन सबको मैं सैल्यूट करता हूँ। लेकिन यहाँ पे मैं ये शब्द भी बोल के जाता हूँ कि ये ऊंट के मुंह में जीरा का फोरन है। इतने भी चीजें हो रहे हैं ना, अभी बहुत कुछ। आप एक बार साथ बैठ के देखिए, उस पेशेंट के साथ में, उस फैमिली के साथ में। ये कोई जंग नहीं, ये वर्ल्ड वार है कैंसर का, जिस घर में होता है। हाँ, तो ये बहुत अभी काम करना बाकी है, और सिर्फ फंडिंग का नहीं है, उसके अलावा भी बहुत सारी चीजें हैं जो कि हम उनके साथ पग से पग मिला के चल सकते हैं।
जी, thank you so much, Dr. Chitra, Dr. Kumal. Yeah, Mr. James.
Yeah, Vivek, just one last quick word.
Please.
When we talk about closing the care gap, it's all about equitable care. So the
Correct.
equitable care with respect to India, it's not just the numbers. Of course, numbers are priority, because out of 20 lakh or 14 lakh cases, probably 20% is getting treated. So when we talk about the quantitative aspects, let us also talk about qualitative aspects. Quantities and qualities have to travel parallelly as far as the treatment of cancer is concerned. Because when you talked about stretching the prices, I want to bring in quality. One question that all of us have to answer is, at what price you want to buy, or at what quality you want to buy? Like the same drug at the lowest cost, can it be approved by an US FDA regulatory or an European regulatory? That is also important, because we don't want the cough syrup fiascos which we came across. As a country, we could be a pharmacy for the globe, but then we also need to take care of our quality. I mean, it was just a small speck, but still it matters. I mean, it brought down our image, and we need to be, when we talk about closing the care gap, the equitable delivery of care also talks about the quality of care, which it should be equitable. So talking about the pharma industry, please don't talk about the price alone. Also talk about quality products, quality companies, because it is a matter of pride for India.
True. Absolutely.
That's where I want to start. Thank you.
Absolutely. And I really respect it, because it's a very important point, because it's a herd mentality, like we keep going behind L1, but is L1 really L1 or it is not? Well, thank you so much, Mr. James, Dr. Chitra, Dr. Kunal, Mr. Sanjeev. It has been wonderful speaking with you all. It's a very small time that we could devote today, but the journey continues. We keep meeting, we keep discussing, and we keep evolving together. Thank you so much. And
thank you.
Thank you
now,
so much.
Thank you. And now I would like to invite Dr. Ratna Devi, who is representing Daksham, which is a patient advocacy forum. And Ratna ji, please take the lead and invite the panelists.
Thank you, Mr. Vivek. And being the last panel, I have the challenge of keeping everyone engaged on a Sunday evening. But the closing remarks from James were very revealing. I mean, not only about the fact that only 20% of patients are actually receiving treatment, but also that quality has to take center stage, and it is not just the numbers that we are talking about. On my panel today, and we will be discussing the topic, can advocacy groups facilitate for optimum implementation and usage of government schemes? And a lot has already been said about what patient groups can do, why there is a gap, and what kind of work that patient groups can take. Sanjeev ji has said a lot about how to get patient groups together, why it is important to unite all the patient groups. But what we would like to understand is there are several government schemes, and are patient groups aware of these government schemes? If they are aware, are they advised about the choice that is available to them? And are they able to avail the full benefits of these government schemes? If not, what can patients and patient groups do to increase the optimum implementation and usage of these government schemes? I have four excellent panelists with me. Joining me is Mr. Jaikumar Mane. He's a medical social worker from Tata Memorial Hospital, Mumbai. Welcome, Jaikumar ji. I also have Dr. Arun Chandrasekharan. He is a medical oncologist from ISPOR Calicut, Kerala. And Dr. Arun, welcome to the panel. I have Miss Vandana Gupta, who is the founder of WeCare. Welcome, Vandana ji. I also have Dr. Ramana, who has kindly stayed back and agreed to join us on this panel. Miss Urvashi, who was my panelist, has joined an earlier panel because she had some other commitment. So thank you so much for joining today. And we've heard a lot about the availability of government schemes. And I will start my first question with Mr. Jaikumar. Jaikumar, you worked in one of the largest hospitals that offers cancer treatment. तो आपके हॉस्पिटल में कौन-कौन से स्कीम्स अवेलेबल हैं और ये स्कीम्स क्या सभी को उपलब्ध हैं और नहीं है तो क्या चैलेंजेस हैं?
थैंक यू पहले मैं विवेक एंड उसकी टीम को इनवाइट करने के लिए और थैंक यू मैडम। मैं हॉस्पिटल में जो हमारे स्कीम है ये आयुष्मान स्कीम ये तो चल रहा है। उसके साथ महाराष्ट्र में ये हॉस्पिटल है तो महाराष्ट्र के लोगों के लिए एक महात्मा फुले जन आरोग्य स्कीम है वो भी चल रहा है, जिसका राशन कार्ड महाराष्ट्र का रहता है तो उनके लिए ये रहता है महात्मा फुले स्कीम। उसके साथ बाकी जो स्कीम रहते हैं जैसे अभी उड़ीसा का है तो बिजू कार्ड चलता है। गोवा का मेडिकल फैसिलिटी रहता है तो उनका अगर रेफर लेटर लाया तो उनके पास से भी होता है। तो ये जो अभी स्कीम चल रहा है ये तो चार चल रहा है। उस हिसाब से हम उनको एनरोलमेंट करके आगे का उनको मेडिकल फैसिलिटी प्रोवाइड करते हैं। आयुष्मान में बहुत सारे लोगों का क्या रहता था कि पहले यहाँ पर उनका एनरोलमेंट हो जाता था और उनका ट्रीटमेंट दिया जाता था, लेकिन अभी वो एनरोलमेंट यहाँ पर बंद कर दिया है क्योंकि बहुत सारे बोगस ऐसा कार्ड बनते जा रहे। तो अभी वो एनरोलमेंट उनके राज्य में होता है तो उस वजह से क्या होता है कि पेशेंट पूरी तैयारी के साथ इधर ट्रीटमेंट के लिए आता है और उनका प्लान जब होता है तो वो पता चलता है कि वो कार्ड उधर बनाने का, तो बहुत सारे फैसिलिटी नहीं ले पाते हैं। तो हमने हॉस्पिटल में अभी एक नया सॉफ्टवेयर डेवलप किया है कि वो पहले दिन से ही उनको उनका एनरोलमेंट है क्या नहीं, उसमें क्या प्रॉब्लम में डॉक्यूमेंट में वेरीफाई किया जाता है और उसमें कुछ दिक्कत है तो उनको उसी टाइम गाइड करके ट्रीटमेंट चालू होने के पहले जो 15-20 दिन का जो गैप रहता है उसके पहले उसका एनरोलमेंट पूरा करके जब ट्रीटमेंट प्लान हो जाएगा उस टाइम उसको कैसे एनरोल करके उसका फायदा उसको ट्रीटमेंट में कैसे दिया जा सकता है। ऐसा एक सॉफ्टवेयर बना है जैसे कि कोई पेशेंट पहले दिन हमारे पास आता है तो हम उनको ऑनलाइन रिक्वेस्ट डालते हैं। आयुष्मान और महात्मा फुले काउंटर जो बना है वहां पर एक ऑनलाइन रिक्वेस्ट डालते हैं, एल्गोरिथम सॉफ्टवेयर का नाम बना है। तो रिक्वेस्ट डालने के बाद वो पेशेंट वहां पर जब जाता है तो वो चेक करते हैं कि किस लिए पेशेंट भेजा है, तो वो रिक्वेस्ट एनरोलमेंट के लिए तो उसका सब डॉक्यूमेंट वेरीफाई होता है। अगर एनरोलमेंट हुआ है तो हमें दिखता है कि इसका एनरोलमेंट हो गया है तो नेक्स्ट रहता है कि इसका ट्रीटमेंट अगर प्लान हुआ है तो उसका ट्रीटमेंट में बैठ रहा है कि नहीं देखने के लिए बोलते हैं। तो वो उसके सब ट्रीटमेंट प्लान डॉक्टर से लिख के लाने के लिए बोलते हैं। अगर वहां से रिजेक्ट हुआ तो हमें पता चलता है कि वहां से रिजेक्ट हुआ है। तो हम हमारे जो हॉस्पिटल में जो अलग अलग गवर्नमेंट स्कीम है, नहीं तो हॉस्पिटल फंड है, ट्रस्ट है, उनके माध्यम से हमको उनको देते हैं। सेल्फ पॉकेट जितना बचा सके वो हमारा प्रायोरिटी रहता है। तो ये एनरोलमेंट जैसे पहले 30% तक होता था, अभी 50-60% के ऊपर जा रहा है और आगे भी हम 100% करने की कोशिश कर रहे हैं। ये एक
हाँ जी, ये तो बहुत बढ़िया आपने बताया। आपने जो एनरोलमेंट किया है, अब हमें ये भी पता है कि कैंसर्स भी कई तरह के होती हैं। तो जो आपके महात्मा फुले स्कीम है या फिर आयुष्मान भारत स्कीम है, इसमें सारी कैंसर्स कवर होती हैं कि कुछ ही होती हैं? और जिनका नहीं होता है उनके लिए आप क्या करते हैं?
जैसे आयुष्मान का है वैसा ही ये है कि जैसे केमो रहेगा तो 5,000 देते हैं, कुछ केमो के लिए थोड़ा ज्यादा अमाउंट रहता है उसमें, और इसमें ज्यादा डिफरेंस नहीं, सिर्फ ये महात्मा फुले रहता है वो 1.5 लाख तक सपोर्ट करता है। और उसके बाद फिर आयुष्मान का फैसिलिटी वो यूज कर सकते हैं जैसे 5 लाख रहता है, लेकिन जो ट्रीटमेंट रहता है उस हिसाब से उसको सपोर्ट मिलता है। 100% ऐसा कोई भी नहीं मिलता। जैसे अगर सर्जरी उसमें बैठ रहा है तो आगे का सपोर्टिव केयर उसको नहीं बैठ रहा है, तो उसके लिए वो पेशेंट हमारे पास आता है। जैसे कि केमो रहेगा तो केमो ज्यादा अमाउंट का रहेगा तो उसको वहां से हेल्प नहीं मिलता है, तो हम अलग अलग ट्रस्ट, पहला रहता है कि हॉस्पिटल जो फंड रहता है उसको हम देते हैं। जो भी पेशेंट हमारे पास आता है, मतलब हॉस्पिटल में कम से कम 40,000 तो 45,000 न्यू रजिस्ट्रेशन हर साल होता है हमारे। तो जो पेशेंट हमारे यहाँ पर आ जाता है तो उस आज का उसका ट्रीटमेंट क्या है वो देखा जाता है। आज का उसका ट्रीटमेंट ना रुक जाए इसलिए पहले हम प्रेफरेंस देते हैं कि हॉस्पिटल में जो फंड है उसको दिया जाता है। अगर उसके साथ ट्रीटमेंट में थोड़ा टाइम है तो हम क्या करते हैं, अलग अलग ट्रस्ट है वो ट्रस्ट के लेटर बना के उनको ट्रस्ट के पास भेजा जाता है। तीसरा रहता है थोड़ा, अगर जैसे किसी का सर्जरी 1-1.5 महीने का गैप है तो CM-PM फंड रहता है तो उसके लिए अप्लाई किया जाता है। तो अलग अलग ये उसके ट्रीटमेंट के हिसाब से हम अलग अलग क्राइटेरिया के हिसाब से अलग अलग ट्रस्ट, हॉस्पिटल फंड और गवर्नमेंट स्कीम का अप्लाई करते हैं।
Thank you. Thank you so much. And that brings me very nicely to our next panelist, Ms. Vandana. Vandana, you have had extensive experience advocating for access to cancer therapies. And as Jaikumar just said, that some of these schemes do not cover the full treatment, and therefore either surgery is covered or chemotherapy is covered or some partial coverage is there. So in your opinion, what can we do to ensure that full coverage is there, and how can advocacy groups play a part in it? Is Vandana ji there?
No, I think she had to join in another program, and she had to rush kind of. She waited a lot, but then we got delayed a bit.
Okay, no problem.
Yeah.
So I will ask Dr. Arun. We just heard Jaikumar ji saying that some patients receive a part of the treatment, and for others, they try to get supportive therapy from other means like trusts or some charities. So as a treating oncologist or as a physician, what are the challenges that you face when patients come who are eligible for government schemes and who then are put on those schemes but do not get the complete treatment?
Yeah, so thank you, Vivek, for the invite. So in the setup where I work in a corporate government, a corporate setup in Kerala. So we do not have the Ayushman, or obviously due to political issues of Kerala in the center, but we do have our local insurances like Medicep, which is for the government officers. We have ESI and ECHS. So as rightly put, for ESI and ECHS, everything is covered, all modalities. But for things like Medicep, for example, we have chemotherapy and radiation covered. We do not have oncosurgery covered. So that puts us in quite a fix, because when you have a patient, for example, rectal cancer, which requires 3 modalities of treatment, and the patient is not very financially sound, it makes it difficult for us to counsel that, okay, you got to take chemo, you got to take radiation, but for surgery, you might have to pay. So in that situation, there are 2 options for our patients. One, our institute, our management has a special package rate for those kind of patients. And there's something known as the ISPOR Foundation, which kind of finances maybe around 30-40% of their costs. So we try to enroll the patients in them, in those schemes, but there's still some out-of-pocket coverage that the patient has to put in. So if the patient cannot afford that as well, we have to look for another center which does the surgery under the scheme. So we kind of refer this patient to another institute. For example, we have a medical college, a private medical college. They do not have facilities for chemo and radiation, but they do have surgery covered under this scheme. So our oncosurgeon travels to that medical college and does the surgery under the scheme. So we kind of do a big workaround. It's not ideal, but at least the patients do get the care that they want. It won't be as cutting edge because we've got frozen section, all the latest techniques of surgery. But for that patient, there will be a little bit of compromise. And with this, almost, I would say 80% of our patients, we are able to, offer the best possible care.
Thank you, Dr. Arun. And you bring a very important perspective into the discussion about multiple modalities of treatment for a single patient. So a patient might not be just requiring chemotherapy or surgery or radiation. And also if there are, reoccurrences of the same cancer in a more advanced stage, then maybe other treatments are required. However, most packages are not customized to be able to manage these kind of requirements. So the question is, who decides these packages, and how, how is it that the judgment is arrived at this is the best package that will deliver the best results to the patient? And in most countries, there is a process called a health technology assessment that is conducted, and it is a scientific process through which medicines or technologies are included into the payment mechanism or the packages that are there at the national level. So I'd like to bring in Dr. Ramana. I can't see him. Yeah, sorry. So, and he is a patient who has been on treatment for a very, very long time, and he has received targeted therapies. And we know that in Ayushman Bharat, there is a mechanism by which a request for inclusion of new therapies can be made. And Dr. Ramana has had an experience of applying through this portal. So we would like to hear from him as to what kind of challenges he's faced, what are the processes involved, and whether there is a scope for patients and patient groups to use this portal to demand for new therapies to be included into the national packages. Dr. Ramana, over to you.
Yeah, thank you, madam. Can you listen to me?
Yes, sir. We can hear you loud and clear.
It's pretty late for everybody. Well, yes. It's like this. Actually, I didn't know much about advocacy. All I knew is that I want to first get cured, and the moment I had a pleasant time and my quality of life improved, I thought, why not the others should get this one? So, of course, the lung cancer group has inspired me a lot. I made an application. First of all, the application form itself is extremely complicated. The moment you look at it, you feel like, okay, thank you. Let us not go ahead with that. Actually, it could have made very, very simple. The technical details they want, the various other things they want, they expect the people who fill it up, he already has a good knowledge of anatomy of a gray. Whereas I am simply an engineer. So even then, I attempted, made it pretty simple for me. I only said, there are certain new drugs that have come up. I gave an example of 4 to 5 drugs which are being used by a number of doctors, but they are not a part of HBA. I checked about 67 pages of HBA to find out which are the drugs which are allowed. So these are not part of the drugs which are told. And in fact, very senior doctors helped me in identifying those things. The only problem is they say that we can't approach it. It's better that you approach it. I said, okay, all right. Then I kept those 4 or 5 drugs. I said, these are very useful. I'm giving it as an example. And you may kindly include these things as a part of it. Then, my God, it has taken such a long time with them. And it went on from one person to the other, one person to the other. I started in 21 December. It went on up to 22 March. And in 22 March, somehow they suddenly took good decisions. And they said, yes, we are going to process your application. Well, first they said that we require some additional information. So whatever I could, I have given them. But the main problem that I feel is coming is this particular targeted drug is something which is not actually executed within the premises of the hospital. This is something which is actually given only in the hospital, in the patient's house. So they say that fundamentally they are supporting only the treatments which are given by the hospital, because we don't know what is happening, whether the patient is really using or he is selling it. So I do agree. But then I said, well, at least, such an amount of approaches you can make so that it can be given. As a matter of fact, that was more or less the end of the matter, end of the road. Then I gave another application telling that, well, I did not get proper answer for it. So kindly just look at it. They said, okay, we are again looking into it. They said, we have referred the matter to NHA. Because now, as you said, there is a specific technical assessment committee. They will look into the particulars that you are given. And they said that every year we are including a few of them. Some of them, what I said, they said we have already started the method of including those. Because I mainly saw breast cancer is one of the most important ones, then lung cancer. So identified the normal drugs which are already being given by the doctors. But the doctors naturally said they are very costly. As it is not a part of a HBA, the patients are not getting the benefit of it, nor the insurance companies are giving the money. So that's where it stands. So I said, okay, I have made my effort. And at this stage, well, I require a bigger support. Then I came to know about the advocacy groups, which I never heard of it. So now Vivek and Sanjeev, they are the people who are taking up these causes. I'll be extremely happy. I'm 84. Well, I do hope that during I am alive, I will see some progress in this particular matter. Started in 21, now it is 24. So, well, you see, it requires a lot of perseverance to continue and do it. It has taken for me number of days of work to fill up each. You kindly look at that particular one, the application form is threatening actually. So I wish it could be made a little bit more simple so that the net finally what the patient wants, whether that is acceptable or not. That's what is mainly.
Thank you, sir. And just to clarify, the application form was not meant for patients; it was meant for industry. And you had the courage to be able to tackle that and fill it and still submit. So maybe one of the outcomes could be to request for a similar, application, which is a simpler language that patient advocacy groups can fill and make requests. And I would also like to maybe, ask Dr. Arun, given the experience that Dr. Ramana had, and the support that he received from doctors to be able to fill that form, do you see a benefit in doctors and doctors association working with advocacy groups to make similar requests? Because right now the portal encourages just the industry to make a request.
Right.
But going forward, since doctors face the challenge, as you have rightly explained, where 2 procedures were covered, but the third one was not, and the interface of the patient is maximum with the doctor, and the disappointment and the frustration is what reflects on the doctor. The insurance agencies and the other people do not face that. So do you see an advantage in pushing for an application portal where doctors and patients, or doctors alone and patients alone, could make new applications, and the advantage of physicians like yourself and physician associations working very closely with advocacy groups like ours and with Sanjayji's advocacy group to be able to make new applications for new and advanced therapies to be included into Ayushman Bharat and other government schemes?
So absolutely, definitely that's an important aspect. For example, my experience, as I said previously, we have this Medicep insurance, which is there in Kerala for the state government employees. So when it launched around 2 years or 1.5 years back, it was very, let's say, bare bones. There were many treatments which were not covered. So we had patients of myeloma where simple bortezomib itself was not covered within. There was no coding which was there. We couldn't fill the code and then submit it. So what we did is we raised this issue with our state organization, and with our state organization, with the backup of the IMA, they've put forward this is the request, or this is the kind of list of drugs which needs to be given. And I believe that the list from Ayushman Yojana was also kept as a comparison to know the rates and everything. And with that, within a few months, actually, which was quite surprising thing, considering things in Kerala are quite slow, things moved forward, and we were able to make a difference, get that new molecules into the system. Now, personally, in Kerala, we don't have the portal system for the patients or the doctors. It's actually done by the administrative staff who are in the background. But I feel that in such a situation where you have new treatments coming, or for example, you have newer generics which come out, which are much cheaper, but we don't see that we cannot, it's not there covered in the scheme. This is where we need to, join hands together. We need the patient advocacy groups, along with the doctors, along with everyone, our administrators, social workers, put things forward to the government. And I think if you attack from all positions, things should move faster and move better. And as you said, it's in the end of the day, it's us who are sitting in front of the patient. So, when it's their pain, it's their loss that we actually feel. The person on the other side of the computer probably doesn't know the implication. It's not that the other person is bad, but he does not see this person. So as an advocacy group, I think if we are able to, bring the gravity, or, tell that, they're able to understand this is the situation, this is the person, and, this patient requires care, I think, there should be no hurdle. Means any human would feel it in their right minds to, push things forward.
Thank you, Dr. Arun. And my last question is to
May I
Mr.
just add a little, so Madam Ramana Rao
Yes,
here?
yes, please.
No, it's like that. When I tried to put any of my views, any of the panels, they were not accepting me. So I put doctor there. I'm a doctor actually in engineering. So I become automatically a member of groups like ISPOR and other things, where I was able to learn and contribute also. The other thing, this terminology is pretty complicated. I thought I lost my kidney. Then after 10 years, I came to know it's not kidney, but it's RCC. that I came to know when they mentioned RCC, I thought it is my building. I constructed the reinforced cement concrete. So then finally, when I looked really into it and asked the doctor, he said, no, RCC is a renal cell carcinoma. I mean, just telling you how ignorant a patient can be. So he has to be supported, and he should not be threatened when he approaches an organization. Thanks a lot. Thank
Rightly
you.
said, sir. And medicine is ever evolving. So
Right.
ignorance is not something that, one should be afraid of. We should keep on asking questions so that you can learn what you don't know.
Yeah.
My last question is to Mr. Jaikumar. And Jaikumar ji, आपने बड़े successfully 2 programs TMH में आप चलाते हो और patients को support देते हो. But हमारे पास में 29 other states हैं या 28 other states हैं, तो हर स्टेट में अगर इस तरह से पेशेंट ग्रुप्स हैं तो उनके लिए आपकी क्या मैसेज होगी फॉर अपटेक ऑफ गवर्नमेंट स्कीम्स बाय द पेशेंट्स? क्या करना होगा उन्हें ताकि ज्यादा से ज्यादा पेशेंट्स को इसका लाभ मिल सके? सर, आपको अनम्यूट करना होगा.
आ रही आवाज?
यस, नाउ वी कैन हियर यू.
तो पहले तो हमने जैसे बताया कि हम पहले दिन से उनको स्क्रीन करने में जुड़े जाते हैं कि ताकि वो आगे का जो ट्रीटमेंट है उससे बेनिफिट ले सके. तो ये पहले करना चाहिए कि सभी स्टेट को कि पहले दिन से उनको डॉक्यूमेंट क्या क्या चाहिए वो स्क्रीन करना चाहिए. जैसे कि बहुत सारे राशन कार्ड, आधार कार्ड, ये रहते हैं मेन डॉक्यूमेंट. तो वो पहले बहुत सारे पेशेंट लेके नहीं आते, तो उसी दिन वो अगर स्क्रीन करेंगे तो आगे का उनका एनरोलमेंट जल्दी हो सके. और आगे का अगर कुछ डॉक्यूमेंट क्वेरी रहेगा, जैसे किसी का राशन कार्ड नंबर दिखता नहीं है, किसी का आधार कार्ड में प्रॉब्लम रहता है, एड्रेस का दोनों जगह अलग अलग रहते हैं, तो वो सब ठीक करके एनरोल, जब तक ट्रीटमेंट प्लान होता है तब तक वो सब सही करके उसका बेनिफिट ले सके. तो ये मेन जरूरी है. दूसरा है कि अगर बहुत सारे पेशेंट जैसे कि दूसरे स्टेट में ट्रीटमेंट लेते थे, अपना स्टेट का जो स्कीम लेता है वो बेनिफिट नहीं ले पाता है. तो हमारे टाटा के भी अभी अलग अलग ब्रांचेस ओपन हो गए हैं, तो हम ज्यादा से बोलते हैं कि वहां पर आप ट्रीटमेंट करोगे तो वो भी आपको बेनिफिट, ज्यादा एक्स्ट्रा बेनिफिट मिलता है. तो हम दूसरा एक चीज बताते हैं कि वहां पर लोकल जो स्कीम है वो बेनिफिट ले लो. तीसरा रहता है कि अलग अलग ट्रस्ट कनेक्ट करना जरूरी रहता है. अगर यह इस स्कीम से अगर बेनिफिट नहीं मिल रहा है तो दूसरा उसका ट्रस्ट से अगर कनेक्ट करोगे तो वो ट्रस्ट के पास से उसको थोड़ा बहुत उसका पॉकेट कम होकर उसका बेनिफिट उसको अलग सा मिल सकेगा। और चौथा रहता है कि जो हॉस्पिटल का जो फंड रहता है वो CSR वगैरह रहता है वो रहता है। ये 4 स्रोत है जो पेशेंट ट्रीटमेंट सही तरह से पेशेंट बीच में ना छोड़ के उसका ट्रीटमेंट कंप्लीट हो जाने की।
Thank you, Jaikumar ji. And just to wrap up what we have been discussing, there are already a lot of government schemes, but how do we increase the optimum utilization of this? So 2 or 3 takeaway points. One is there needs to be more networking and learnings from people like Mr. Jaikumar, Mr. Sanjay, because they already have a lot of experience. There are new patient groups and even some older patient groups, they are still struggling. So how do we bring all of these together into a network so that some of these challenges are not being learned from the bottom of the pyramid? So there is a lot of learnings already there. How can these people learn from them? There needs to be some synchronization between physicians and advocacy groups, so that advocacy groups who are trying to reach out to the government counterparts for inclusion of new schemes or for better utilization of the existing schemes can work with the knowledge that physicians give them to be able to make applications or to follow up on applications. And the third takeaway is that there is an existing portal which encourages industry to make new applications. A request could probably be made as an outcome of this discussion today, that maybe there should be an opportunity for patients to apply in a much simpler format, as well as for physicians to apply in a more technical format. I think these 3 takeaways could be a good way of taking the discussion that we had today forward. Thank you, Vivek ji, and over to you.